Hello, and welcome to the second presentation about palliative care. I'm Eleanor Kenny, the clinical nurse specialist for palliative care in the Fredericton and Upper River Valley. Palliative care provides an extra layer of support to patients and families long before patients reach the end-of-life phase of their illness trajectory. Before we begin, I want to stress that end of life is a phase of palliative care, and it is by no means the entire definition. I'd like to take a moment to acknowledge the importance of the lands which we each call home before we get started. So we respectfully acknowledge that the land upon which we gather is the traditional and unceded territory of the Woolastook people. Their ancestors, together with those of the Mi'kmaq and Passamaquoddy nations, entered into peace and friendship treaties with the British Crown in the 1700s. We are committed to building respectful relationships with Indigenous peoples. We are grateful to be living and working on this land, and we are committed to learning more about the history and culture of the Woolastook Nation. Just to outline the plan for today's presentation, like a bit of a broken record, I'll once again highlight the vast abilities of palliative care for patients and families across the illness trajectory. I actually hesitated a bit to create a presentation about end of life, as I was worried that it would feed into the misconception that palliative care equals end of life care. I cannot stress enough that this is simply untrue. I'll use Ken's story to work through information related to preparing for end of life, signs that death is imminent, comfort measures, managing airway secretions, caring for families, pronouncement of death, and postmortem care. Ken's story represents a fictional patient experience, but his story provides an effective way to help you envision how you would operationalize the learning we're about to embark upon. So palliative care can help people with serious illnesses regardless of their prognosis. It is a patient-centered, holistic approach. It can support caregivers and families who are caring for a loved one with a serious illness. It can also support those who are grieving and living with loss. It is so much more than end-of-life care. Palliative care improves the quality of life and reduces suffering for people with a life-limiting illness. Life-limiting illnesses are serious illnesses that could shorten life and cause death. They have a big impact on health and quality of life. Quality of life is a very subjective concept. It's what you define as well-being for yourself. This includes comfort. It also includes the experiences that are important to people and their ability to enjoy them. Palliative care is whole person care. Illness affects many aspects of the person's life. Palliative care provides support for pain and other symptoms, emotional and mental health, spiritual well-being, and practical needs for daily life. Serious illness affects families and other people who are important. Palliative care also helps caregivers. If the illness leads to death, it also supports your loved ones with their grief. Palliative care is for any stage of illness, whether it's a cancer or non-cancer illness. It helps people to live as well as they can throughout their illness. The earlier you receive palliative care, the more it can help you. Palliative care is not based on a stage of illness, nor on a prognosis. For some people, palliative care is helpful as soon as they find out they are sick. You can get palliative care while receiving other treatments. Palliative care is especially helpful when someone is in the last year or months of their life. Unfortunately, sometimes patients are very young, and palliative care also applies to them. Although end-of-life care is a small part of palliative care, today's presentation will focus on that small part of the illness trajectory. So Ken's story. Ken is a 67-year-old man with very advanced hepatocellular carcinoma, secondary to hepatitis C and cirrhosis. He has a very supportive family, a wife who is healthy, and 3 children who live nearby with families of their own. His wish is to be cared for at home for as long as possible. Events are often predictable, but there's always the possibility that they will happen more quickly than anticipated. So it's really important to be prepared. Plans should be made for unexpected events. Who should be called? If it's during physician hours, if it's after hours. In New Brunswick, Extramural is often the point of contact in the community, and they coordinate with the physician. The family, when at home, need to be educated not to call 911, and there should also be plans in place to avoid emergency room visits. Goals of care discussions ensure that we're providing the treatment and procedures that align with the patient's wishes and values. Values and wishes change over time, though, so this is never a one and done conversation. This conversation happens at all the transition points along the way. When discussing end of life, this should include determining and encouraging patients and families to participate in advanced care planning discussions, appointing and legalizing power of attorney, as well as ensuring that the appropriate DNAR order is in place. Again, it should be aligned with the patient's wishes and values. It's also important to determine the patient and family's preferred place of death. Do they want to die at home, in hospital, or at hospice if it's available? Ken has a legal will and power of attorney in place. In addition, he has had several conversations with his family regarding end-of-life decisions. They are aware that he values quality over quantity. If symptoms and complications such as delirium are not immediately reversible, he would opt for a natural death, with comfort being the most important factor. Ken wishes to stay at home as long as possible. So preparing for location of death, it deserves a little more attention in terms of what we're talking about. Educate, explain, and discuss. Again, not a one and done conversation, but a topic that's revisited by healthcare providers frequently. Ken wants to stay at home for as long as he can. He agreed to a palliative care consult when his CAT scans showed signs of disease progression despite being actively treated for his disease. At the time, Ken was quite well and verbalized that he knows that his time is now limited and that he may only have a few months left to live. His pain is well managed, and although he was a bit jaundiced, he didn't have any itching or other liver type symptoms. When seen by the palliative care specialist, Ken is referred to the extramural program so that he and his family can have additional support in the home. They'll visit every 1 to 2 weeks to start, and as his condition changes, they'll increase the frequency of visits. Nursing is the only discipline involved in the beginning. Part of their interventions will be to reinforce education related to the disease, assess symptoms, and encourage the patient and family to call them as first contact if they notice any changes in condition. Teaching the family about the progression of liver disease is important in Ken's case. For example, disease progression and treatment includes reduce confusion by keeping ammonia levels stable, so using lactulose for as long as possible. Treating ascites for comfort, so he might require a tap, and sometimes increased ascites presents itself as increased shortness of breath. Making sure that the patient and family are aware of that is important. And manage itching. When it develops or if it develops, using medications such as antihistamines and special creams. Also letting families know that at some point the patient may no longer be able to take oral medications. They need to understand that they may need to give injectable medications. This is a point where some people draw the line. They can't imagine giving somebody a needle. Helping families understand what is potentially coming helps them prepare for the situation and helps them make decisions about what they may or may not be capable of managing at home. In Ken's case, Ken's wife has a needle phobia and would need to draw the line at having to give a needle to Ken. However, one of his children is a physiotherapist, so she has some medical background and feels like she could step in to manage injectables when the need arises. Additionally, the family needs to know how to recognize signs of decline and progression towards end of life. And we'll talk about the signs of imminent death in a few minutes. So again, educate the family not to call 911. Call EMP, who will communicate directly with the covering physician. Since Ken's desire is to stay home for as long as possible, there should probably be a backup plan discussed if the family can't manage him until end of life. He may have to go to hospital or, if available, hospice. Ensuring that appropriate referrals are in place helps alleviate the patient's and family's level of anxiety. Preparing for emergencies. It doesn't sound like it, but the inability to swallow as patients begin to fail is considered an emergency. If they're unable to take their oral analgesics, in Ken's case, if he can't take his lactulose, it's going to lead to a very precarious situation. For Ken, his physician has sent prescriptions for injectable medications to the pharmacy, including Haldol and Midazolam, because once Ken can no longer take medications, he won't be able to take lactulose, which will lead to an increase in his ammonia levels, which will have a tremendous impact on his cognition, and likely he'll start to exhibit delirium-like behavior. The EMP nurse has provided syringes and needles for subcutaneous medications and started some teaching related to administering medications via butterfly. In addition, a hospice referral has been sent so that Ken is on the radar and this helps to facilitate an easier hospice admission if the family reaches their breaking point. The EMP nurse and physician have both encouraged the family to reach out to their funeral home of choice to begin some of the final preparations. So just recognizing imminent death. So some of the things that you need to teach the patient and the family, more importantly, about is that as death becomes imminent, the patient will experience increased periods of sleeping and unconsciousness. Sometimes there's changes in respiratory rate and rhythm. They may experience Cheyne-Stokes breathing or agonal breathing. They might get a weak pulse. Their skin becomes mottled, often starting in the extremities and the more dependent areas. Their extremities will become cold, and they often experience airway secretions. So gradually, Ken is sleeping for many hours of the day, and the family is wondering why. So the nurse takes this opportunity to teach them about the signs of imminent death. This is something that EMP will reinforce as needed at future visits. Discussing these changes ahead of time with families so that they are prepared. It is of the utmost importance to use plain language when speaking with family and caregivers. For example, pattern of breathing may change. It might slow down, might appear to stop for a few seconds and then start up again. It's also important to normalize changing breathing patterns, really normalizing any changes, actually. These changes are normal and do not indicate suffering. Gasping following apnea is normal. It is not suffering. Just really helping the family understand what to expect, and that it is not always equated with suffering. Usually as conditions deteriorate, physicians will do a comprehensive review of medications in an attempt to reduce the pill burden, especially when swallowing and ability to drink are impacted. As a nurse, you can suggest that it might be time for this to happen if it's not happening. The point when Ken starts sleeping more, the EMP nurse communicates this change to the physician, who makes arrangements to visit Ken. During the visit, the physician also takes the opportunity to discuss what happens as death becomes more imminent and suggests that this might be a good time to take a look at Ken's medications and discontinue some of them. He helps Ken and his family understand this better by educating them about mechanisms of action and simply the change in the body's needs as systems begin to shut down. When death becomes imminent, Kent has made it clear that his focus is on comfort. So the family is quite comfortable with reducing his pill burden and only taking those things that are related to keeping him comfortable. So what are comfort measures? It is absolutely inappropriately to suddenly, without discussions with the patient and family, discontinue all medications and order comfort measures for end-of-life care. These discussions should have occurred earlier and the patient and family prepared for the possibility so that it doesn't become a rapid overnight transition. It is inappropriate to initiate scheduled opioids if none were required before this moment, and the patient is not showing any signs of pain or shortness of breath. Medications and sedatives should be initiated based on individual patient needs and clinical assessments, based on appropriate care plans and negotiated goals of care. Turning and positioning, mouth care, and basic care become the cornerstones of the care plan, after symptom management, of course. The EMP nurses encourage the family to play a role in providing comfort care by helping with basic care and by continuing to talk to Ken, reminisce, play his favorite music, etc. Managing airway secretions is part of end-of-life care. As death becomes imminent, respiratory or airway secretions often become audible. These are often more distressing to the family than they are to the patient. Manage upper airway secretions by repositioning patient and reassuring the family. If they are mild to moderate secretions, use the snoring analogy. Like when someone snores, it doesn't bother the person, it bothers those around them. For example, if my husband is snoring in the middle of the night when I can't get to sleep, it's not bothering him one bit, it's keeping me awake. If it's a severe upper airway secretions, you can try repositioning, reassurance, and maybe try an anticholinergic like glycopyrrolate. You might also know that as Robenal or scopolamine. Those are usually subcutaneous. And if it is a lower airway secretion, so if you listen to the lungs and it's crackles in the bases, that's an indication of a lower airway secretion. And often diuretics are required, and Lasix can be given subcutaneously to try to decrease the discomfort from that. So family members may also suffer when a loved one is dying. So it's really important to treat them gently and to acknowledge their concerns. So explain things in a gentle and caring manner, take time to explore their concerns, give them permission to care for themselves, and help them understand and recognize the normal dying process. So this slide is a bit of a departure from Ken's case, but I think it's got some important points to consider, and it'll help us understand how important it is to support families as they travel through towards end of life. So there's a video here that I'm hoping is going to work.
The following dramatization presents two ill-structured scenarios. It's not intended to model, but rather to promote critical reflection and group discussion about the things family members might experience close to end of life, especially when not well informed and supported. In the following scene, a patient is in the last hours of life and dying from cancer. She is attended by her husband, who wishes to be with her until the end. He is concerned and distressed and expresses his concerns to the care team. As you watch the segment, consider the following questions. What is happening? What issues does it raise? What emotions come to your awareness? What implications does it have for how we practice?
How are you doing?
I'm okay. When she breathes like that, is she in pain?
No, this breathing is just part of the process.
Isn't there something more we could do for her? I mean, it's really hard watching her like this, and worrying she might be suffering.
Now, let's review the scenario again. Consider the following questions as you watch. What is happening? What issues does it raise? What emotions come to your awareness? What implications does it have for how we practice?
It's just not right. I mean, we treat our animals better than this. We don't let them linger and suffer like Julia's suffering. We call it being humane.
In what way do you feel Julia is suffering?
Well, You just have to look at her. I mean, she's yellow, for heaven's sakes. She's breathing funny, making wheezing sounds. She's suffering.
Alex, I understand that you think Julia is suffering. But the color of her skin is a result of her liver failing and doesn't cause her any pain. That wheezing you hear is a result of her unconscious state and the way the air is flowing over her vocal cords. The weird breathing is a sign that her body's respiratory control is being affected by the toxins in the liver.
Right, and just how do you know that?
It's part of the natural process of dying. It's the body's way of gradually shutting down systems. It's difficult for us to know if someone is actually suffering because no one has ever been able to tell us what they're experiencing. So we have to go by facial expressions and movements.
That's it. That doesn't sound very scientific to me.
Well, that may be so. But we feel that if someone is sleeping peacefully, then they are comfortable. I think that the process of dying is much like the process of being born. There's a labor beforehand, and there's no way of knowing how long that'll take.
Maybe that's so, but it's hard to just sit there and watch her slipping away like that.
I'm sure that it must be, Alex. You have a little girl, don't you?
Yeah, why?
Where is she when you're here?
Well, she's with my wife's sister sometimes, and other times she's with my mother.
Sounds like you have a supportive family.
Yeah, they've been great.
Why don't you ask them to share this vigil with you? And you go home and spend some time with your daughter. She needs you too.
I suppose. But I'm afraid that Julia will pass away when I'm not there with her. I don't want her to go away when I'm not there. I feel so guilty. There's nothing I can do, but I have to be there for her. Even if all I can do is sit by her side and wait.
Alex, there are some things you can do for her. Like keeping her lips and mouth moist, massaging her arms and legs, playing some music she likes and some other things too. Let's go and see her, and I'll show you.
So this video showed a young husband at the bedside of his wife who's dying of advanced cancer. She's close to death. Although she looks comfortable and her breathing is changing, the nurse cares gently for the patient, explaining that breathing changes are just part of the process. The video itself illustrates the dangers of families projecting their own suffering and not recognizing the normal dying process and asking for interventions based on that projection. So I thought it was just important to look at that because, first of all, I think that the nurse and the doctor both demonstrate some really good things, discussions, points, the way they word things that could be very helpful to our own practice. You could sort of adopt them as you care for patients. So I thought it was important to share that so that we could really see in practice somebody having a conversation, one of those difficult conversations. Even though it's hard, it's important to have them. So I'm going to move on to pronouncement of death. So pronouncement of death, nurses, both RNs and LPNs, may pronounce death in the event of an expected death. So Ken is able to remain at home until his death. When he dies, the family calls the EMP nurse who comes to the house to pronounce Ken's death. She allows the family to remain at Ken's side while she does her assessments, which includes observing Ken for breathing and any other movement, confirming that there is no pulse, no heart sounds, no lung sounds, and checking for pupil dilatation. Once this is completed, she documents the findings in the patient record and notifies the funeral home that Ken has died. Technically, it's a family responsibility to notify the nursing home, but my contacts at EMP tell me that most of the time nurses remain with the family till the funeral home gets there, and that they do take that on as something that they do. And they also notify the physician that the patient has passed away. If it's in the middle of the night, they usually wait till morning to notify the physician. And preparing the body at the end of life focuses on preserving the body, maintaining dignity, and providing comfort to the family. At home, in the home care setting, so in Ken's case, it's very basic. The nurse removes any tubes and other medical equipment that's there. And she calls the funeral home and remains with the patient until the funeral home arrives. And then the funeral home actually takes care of getting the death certificate completed by calling the physician or nurse practitioner. But I think we should also talk about sort of deaths within a facility as well. So most of the time, you would prepare. So you gather what you need, you get a clean gown, absorbent pads, ID tags. You do have to really be mindful of any cultural or religious beliefs regarding postmortem care, and follow any instructions from the family or religious leaders. And that would be true for both in a facility and at home. Position and clean. So in the hospital setting, the body's placed in a supine position with anatomical alignment. The body is cleaned, usually paying attention to areas with bodily fluid, removing medical equipment like tubes and dressings. Usually the care team in a hospital setting dresses the body in a clean gown and puts absorbent pads under wherever there might be some potential fluid leakage. They also secure the body in a body bag for transport, and that depends. Not all institutional policies require body bags. Some just cover them with a clean sheet. You would wear PPE when you're doing postmortem care and be aware of legal and procedural requirements for handling death. So whether if an autopsy is required or if it's a coroner's case, then there are certainly other things that need to be considered. And then in terms of documentation, nurses would obviously document in the health record the pronouncement as well as the events leading up to the death. In a facility, it's also usually the death certificate is usually filled out by the physician and it's kept at the hospital until that happens. And then at the hospital, admitting sends it to the funeral home. Family support is something that's very important. You need to offer support and information to the family about funeral home arrangements, provide emotional support and guidance during the difficult time, ensuring that they understand the process and have opportunities to say goodbye. We never rush families around. We always afford them the opportunity to stay with their loved one as long as is required. But completion of the death certificate is not a nursing responsibility. It is the responsibility of the attending physician. So I think I said this already, but in Ken's case, his death occurred at home. So the nurse comes to the house, pronounces death, removes his butterfly, and calls the funeral home. She remains in the home until with the family until the funeral home arrives. And then the funeral director will contact the physician to have the death certificate completed. Healthcare providers require support too. Those who work in palliative care all the time deal with death often, and that can certainly weigh on you. And those who don't deal with it often also require a lot of support because it's not part of who they are or what they know. So ask your coworkers how they're doing. Always allow opportunities to share feelings and acknowledge the deaths of those you have cared for. We don't always do a good job of taking care of one another. In the hospital setting on the PCU, or the palliative care unit. We discuss the patients who died the previous week at the beginning of each of our weekly patient rounds. How it went, was the family okay? Did it present any challenges to caregivers? Those kinds of things. This provides an opportunity for the team to provide support to one another. Debriefing is important, but unfortunately our systems are set up in a way where there is not a lot of formal debriefing opportunities for staff. We really need to rely on our employee and family assistance programs for formal debriefing support. But know that those are available. Long-term care settings have other challenges because not other challenges, but I think that the residents become like families to employees and to the other residents as well. So a lot of settings will hold some sort of death ritual. Our local hospice, all the staff accompany the body from the building in an honor guard type manner when the funeral home comes to pick up the body, and the family is included in that as well. So it's just that last show of respect that they have for that particular patient. So things like that do happen. And then finally, just a few final tips and takeaways. Remember that preparing for death is something that needs to be started early. It's really important to have the hard conversations. They're hard, but the more you practice them, the better you get at them. And they're so meaningful to patients and families. Review goals of care, treatments, and medications often. They're not one and done conversations. They need to be reviewed often. Prepare for the inability to swallow and other emergencies. So just try to anticipate what might happen, and educate families on what to expect, the disease progression, all of those kinds of things. Knowledge is power, and in this case, knowledge helps families be better prepared. It is difficult to lose a loved one, and I don't think we ever can fully prepare for it, but we can play a big role in trying to alleviate the trauma of it. Thank you so much for the opportunity to share this with you today. If there are any questions or comments, feel free to reach out to me at any time. I'm 100% committed to spreading knowledge about palliative care with the end goal of ensuring patients receive the best care possible regardless of where they are. Thank you.